imaging of the brain, the head with IV contrast, and then we'll talk about CTA of the central vessels of the head. So we're going to begin our study of contrast enhanced CT brain with a brief mention of the venous phase of the brain enhancement, which, when indicated, is most commonly performed along with the non-contrast CT head. During late venous phase, there's more contrast in the venous sinuses bathing the brain. Delays are commonly 60 to 90 seconds after the start of injection. Delays up to 5 minutes can be utilized to detect late enhancing neoplasm. The injection rate, you usually use anywhere from 75 to 100 IV milliliters of contrast at 2 milliliters per second. And like I said, you go from a 60 to a 90 second delay after injection. Advances in multi-detector CT systems and image post-processing techniques have expanded the role that CT plays in evaluation of cervical craniovascular disease. Although cerebral catheter angiography and digital subtraction angiography, which are both performed in the interventional department, are still generally regarded as the gold standard for imaging of CVA disorders, those techniques are time-consuming and associated with small but significant risk of permanent neurologic complications. So CT angiography has the advantages of being non-invasive and widely available. This is especially valuable because time is of the essence when patients are suspected of suffering acute stroke. Cerebral CTA can be combined with brain perfusion imaging to assess the viability of the brain parenchyma and its vascular supply. We'll be talking about the perfusion studies next week. Cerebral and carotid CTA techniques provide provide important information about vessel walls. Three-dimensional post-processing of the image data depicts the spatial relationship of complex vascular lesions to the surrounding structures, and these can provide valuable information to the surgeon who's trying to get at that tumor or that close off that bleeding vessel. So the goals of CTA for cervical craniovascular evaluation are: number one, to accurately measure stenosis of the carotid and the vertebral arteries and their branches. Number two, to evaluate the circle of Willis for completeness using 3D reformations and cerebral vasculature in relation to, of cerebral vasculature in relation to other structures. The third thing is to detect other vascular lesions such as dissections or occlusions. To begin the procedure, the patient is positioned as for a routine CT head, supine with the arms by their side. Usually a non-contrast CT brain is acquired before administration of contrast to make sure that the bleed is not going to cover up the contrast, or the contrast not going to cover up a bleed. And in the setting of the setting the scan parameters, thin section images of 0.5 to 1.5 millimeter sections are utilized in a caudocranial direction. So we're going from the bottom up. They begin at the level of C2 to at least 1 centimeter above the dorsal cella. The cranial arteries are the primary focus of the study, and they comprise the circle of Willis. And those are, number one, the right and left anterior cerebral arteries. Number two, anterior communicating artery. 3 is the right and left internal carotid arteries. 4, the right and left posterior cerebral arteries. And 5, the right and left posterior communicating arteries. Although they don't form part of the circle of Willis, the basilar artery and the middle cerebral arteries are also of importance during CTA imaging of the brain and its blood supply. So before the injection of contrast media, we need to ensure that the patient has an 18 to 20 gauge angiocatheter IV site that's functioning correctly. The technologist should check this by forcibly hand injecting saline through that angiocatheter and observing whether there's infiltration near the site. The reason for the large IV site is because the contrast agent's rapidly used or has a rapid rate of 3 to 4 milliliters per second. It has to go in really fast. So you need a big IV that'll facilitate that. Ensure proper timing of the acquisition in regard to the contrast agent bolus. The technologist has 3 methods available. It can set a delay of 12 to 20 seconds after the injection started, or a test injection can be performed where a small bolus of contrast is injected and visually observed for timing of material enhancement. The third thing is the use of automated triggering software such as a SureStart, Monitor Slice, or bolus tracking, which causes the scan to begin at a predetermined Hounsfield unit attenuation value. So you're taking a slice at one spot at so many intervals or so many seconds. You're watching that to see when the vessels are optimally highlighted or enhanced. And that'll be your scan time, or your start scan time. So after the acquisition of axial images, they're formatted into various coronal, sagittal, and oblique planes. 3D techniques are required, are performed with those acquired data as well. You're going to use MIPS, MPRs, surface rendering, and volume rendering. You can pull out all the stops with these CTA brains to turn into the radiologist. You can have some really pretty studies. A type of subtraction technique, which is usually seen in angiography in the interventional suite, can be performed as well. These are called CT angiography source images, and they provide valuable information about acute brain infarct. The subtraction maps are obtained by subtracting the unenhanced CT brain images from the contrast-enhanced CTA source images. It's also important to remember that protocols for CTA depend strictly on technical capabilities of the CT system employed. The study should not be performed, or should be performed on at least 16 slice machine or greater. And generally, with 64 slice systems, 50 to 75 milliliters of contrast at 4 milliliters a second is all you need, with a 15 to 22 second scan delay. The slices are then at 0.625 millimeters, but can be scanned in thicker slices and reconstructed in the smaller slices to reduce the radiation dose. So slide 68 shows indications for CTA brain of the head. They include cerebral aneurysms, intracranial thrombosis, traumatic CVA injury, arteriovenous or AV malformations, and stenosis. Again, these are the vessels that make up the circle of Willis. Familiarize yourself with those, and remember that the basilar artery and the middle cerebral artery are not included in the circle of Willis, but they are very important in supplying blood to the brain. So they're imaged as well, and they're studied as well. This image is a 3D reconstruction of circle of Willis from a superior point of view. And what you're going to do when you've made this 3D image here, you're going to rotate that in 15 to 30 degree increments. You'll go anterior to posterior, you'll go left to right, inferior to superior, just so the radiologist sees that circle of Willis in all angles, all different perspectives. And you see at the top here, the right and left anterior communicating artery, or cerebral arteries, and then here's the anterior communicating artery that connects those two guys, rounds this way becomes the middle cerebral artery, which feeds the middle of the brain. Same on this side as the left. Then you have the posterior communicating arteries that connects the middle cerebral and the posterior cerebral arteries that come off here. The basilar artery comes up left and right vertebrals come up forming the basilar artery, which comes up and joins in here and feeds the brain as well. It's a popular place for aneurysms down here, this basilar artery, so we have to watch that real close. The image on the left in this slide has the brain outline along with the cerebellum and the pons, depicting which areas of the brain the vessels of the circle of Willis supply. So you have vertebral arteries coming from the basilar into the posterior cerebral. This is feeding this aspect, posterior aspect of the brain, comes up to the middle, which feeds the middle cerebral arteries, and then you have the anterior on this side and this side to feed the the anterior portion of the brain. Internal carotids come up this way too. They feed the internal brain. The image on the right is most likely an MRA from an MRI study of the circle of Willis, but it does depict the basilar artery and how it connects, forming the posterior cerebrals right here. It also gives a different view of the anterior cerebral arteries too, how they kind of right here beside each other, they ride up this way. These are images of the circle of Willis in the MIP and a 3D. These are the MIP images here, maximum intensity pixel projection. Sorry. This is a coronal view, and you see here's the basilar artery coming up and spreading out, and the circle of Willis is not really visible that way, but you can see the arteries anyway. And here's just some more of the arteries that are coming up and feeding through the base of the skull here. And here's a nice view of the carotids, the vertebral coming up to the basilar, and then the circle of Willis is in here somewhere, but this is a lateral or sagittal 3D view, and all these vessels are filled as well. All right, so this concludes our study of the CTA brain, circle of Willis. They're becoming more and more popular as the scanners get faster. Probably see a lot more locally than in the outlying areas, but they're a neat study, fun to work with on 3D stations as well. So next time we'll pick up with the brain perfusion studies. See you then.